moving ahead to the next session, this is going to be about individualized immunosuppression in transplantation. To chair this session, may I invite at the dais Dr. Mukesh Sethe and Dr. Rajesh Kumar. To give the first talk, may I invite at the podium Dr. Nishit Mohanty. 13 minutes timer reset, please.
Good morning, everybody. I thank the organizers for inviting me to give this interesting talk. This is regarding steroid-free kidney transplantation. Slide. Steroid-free transplantation, Indian experience. Next. Next slide, please. So, corticosteroid was first demonstrated to be effective to enhance survival of rabbit skin graft in 1950s. And in same 1950s, the clinical use of steroid to reverse severe kidney transplantation was established. Then, from 1960s, the introduction of steroids and azathioprine combination as maintenance immunosuppression was established. But by 80s, it was when this cyclosporine came to the picture. Then by that time, lot of complication of steroids came to the picture. So, the steroids came with its own baggage of problems, starting from hypertension, new onset diabetes, NODAT, dyslipidemia, cataract, glaucoma, bone disorders, bone fractures, and AVN, avascular necrosis of bone. So these are not small complications, or not, the incidence is not that low. Starting from your hypertension 15% to NODAT more than 10% cases, and fractures also very common in this group of patients. So when they found that steroid is good for transplant, it prevents rejection, but it came with lot of complications. So that is why people started thinking to reduce the amount of steroid or stop steroid in their transplant patients. So there was variable approach. When they found that there is a lot of complication with the steroid administration, then many people, they started withdrawing the steroid, or steroid avoidance, or steroid, they started reducing the dose. Like we clinically are using low dose steroid. So by 2006, in USA, almost 1/3 of the patients undergoing transplant are without steroid or the steroid-free transplantation. There are a lot of studies published regarding the steroid-free, the effectiveness of steroid-free transplantation in the literature, but I will just touch upon one short study and one long-term study and one review for your better understanding. So a randomized control trial on safety of steroid avoidance immunologically low-risk kidney transplant recipient. Mind a low-risk kidney transplant recipient. This study is very popularly known as Seller study. And what are the outcome of that? Actually, it is a 2-year multi-center open trial study. They have taken immunologically low-risk non-diabetic kidney recipients, and the total patients were 220. And they divided 2 groups, one steroid avoidance assay and steroid maintenance SM. And you can see the outcome between the 2 groups, steroid avoidance group and steroid maintenance group. Almost statistically there is no difference between the 2 groups. And their conclusion was that further evidence for the feasibility and safety and the efficacy of early steroid-free treatment at 2 years in immunologically low-risk kidney recipients with tacrolimus MMF maintenance regimen. So this is a very big, very long-term study. There are short-term studies are there, a lot of there, but long-term studies are very few. So this is a study that is done in USA, published 2021 in JAMA Surgery, and Their title was Early Corticosteroid Cessation vs. Long-Term Corticosteroid Therapy in Kidney Transplant Recipients. It was a randomized controlled trial, prospective, multi-center, randomized, double-blind, placebo-controlled trial between November 1999 to 2002, and the study was completed in only 2018 and published 2021. And the objective was to compare long-term kidney transplant outcomes of patients randomized to continue or withdraw corticosteroids. And the main outcome was allograft failure from any cause, including death. Allograft failure is censored for patient death, defined by requirement for long-term dialysis or repeat transplant. The result was there are two arms, 191 in the assigned to the withdraw corticosteroid and 194 continue corticosteroid. So their conclusion was long-term corticosteroid may not be necessary as part of a calcineurin-based multiple drug immunosuppressive regimen in low to moderate immune risk kidney transplant recipients. So this is one review actually I'm mentioning. It published in Cochrane 2018. So what they compared the steroid withdrawal versus steroid maintenance and steroid avoidance versus steroid maintenance. So what they found that if we compare the mortality, graft loss, harmful events, there is no statistical difference. But as far as acute rejection is concerned, there is a significant increase in your acute rejection in steroid withdrawal cases, also your steroid avoidance cases. So it is the hazard ratio was 1.77 in steroid withdrawal and steroid avoidance was 1.58. So what their conclusion? So what is the implication of our practice? So implication, the steroid avoidance and steroid withdrawal after kidney transplantation significantly increased the risk of acute rejection. We found no evidence to suggest a difference in patient and graft survival up to 5 years after transplantation, but the data to support the absence of harm is limited due to the low number of events observed rather than small studies. Follow-up periods are too short to draw any conclusion, and long-term outcomes of kidney transplant recipients after steroid withdrawal or avoidance. So next, actually my topics were actually based on Indian study. Actually, I could find only two studies what is published. Maybe more studies will be there. But the most important, publicized and well accepted study was one in study that is low dose rituximab thymoglobulin induction with steroid-free maintenance immunosuppression. Protocol biopsy improves long-term patient and graft survival after kidney transplantation. And here in this study, they have included 1100 patients. It is from Vivek Pathak group from South India. So this is a retrospective analysis of all consecutive transplantation between July 2005 and 2007. They have excluded all diabetics, long-standing elderly hypertensive, and with history of coronary artery disease. And about 2.5% out of this 1142 patients lost to follow-up. So ultimately, they analyzed 1,111 patients, and the mean follow-up time was 5.8 years. So it is a fairly long-term study, and they have used thymoglobulin or rituximab as induction, and IV methadone, and the maintenance immunosuppression, tacrolimus and mycophenolate. So all patients done with protocol biopsy 3 months, and 1, 5, and 10 years after transplantation. All biopsy-proven rejection treated with your methylprednisolone for 3 consecutive days. So what is the outcome? You can see that patient survival at 1 year it is 97, and at 12 years it is 92. Graft survival 97 and 86 and 12 year, and mean creatinine. In 1 year it is 1.2, and year 12 years. So fairly, and no doubt is 1 year it is 1.5, and 12 years is 6.1. So so it is a quite good report, and in comparison 1 year and 12 year, and 70%, around 70% patient remain steroid free at 12%. Out of this, 70% patient remain steroid-free. And biopsy-proven acute rejection at 12%, including 3% subclinical rejection. And cumulative incidence of graft loss was 6.5% at 12 years. So it is a very good outcome. Incidence of BK virus, PTLD are very less. And overall death was 5.2%. So their conclusion, the reason for improved results could be addition of low dose preoperative rituximab to thymoglobin induction, use of tacrolimus-based immunosuppression, aggressive cardiovascular screening, low infection rate due to the steroid withdrawal, aggressive biopsy procedure including protocol biopsies. So they have seen the percentage of patients of prednisolone pre-treatment by year of follow-up. So already I mentioned earlier. So the second study was by Gulati et al. So they have, this is actually short study, study, and only they included 42 renal transplant recipients, and they are given methylprednisolone initially, and on triple immunosuppression, tacrolimus and MMF subsequently, and induction as IL-2 receptor antagonist as the induction. And their result, the study group comprised 42 patients, 6 patients had an episode of acute rejection. All of them were treated with IV medicine followed by oral prednisolone therapy maintenance. Incidence for rejection was similar, the study group compared to those who were on steroid-based protocols. All of them responded to regain baseline renal function. The incidence of infections were similar to both groups. There was no death or graft loss in the steroid-free group. All the 3 children who were steroid-free protocol showed excellent growth, and there was no growth retardation. So their conclusion, this initial experience suggests that steroid-free protocol is safe, efficacious to avoid steroid-induced adverse effects without any significant increased incidence of acute rejection. Then question is, why have not most transplant centers adopted an early steroid withdrawal avoidance protocol? Maybe in India are doing 10,000 transplants. So how many of them are steroid free? So centers, the reason is that many centers, they don't want to use it as off-level, and it has been seen that it has been argued that maintenance dose of steroid in modern era much lower than they are historically, and the side effects of such low dose are minimal, as we are now using in low dose. And steroid is effective in treating acute cell rejection in the most of the centers. Believed to steroid should be renewed in patients who experience rejection episode. So trial outcome, the current unmet needs of steroid withdrawal evidence in kidney transplant, trial outcomes from low-risk transplant population cannot be generalized as high-risk patient. Most of the studies, they have only included your low-risk patient. They have not included the high-risk patient. So that is a gray area that to be, you have to see. It is inaccurate to conclude that complete steroid avoidance is safer only based on less frequent post-transplant diabetes. Only advantage is post-transplant diabetes, but rejection episodes are same. The possibility of de novo donor-specific antibody is realistic concern. So if you stop steroid, there may be DSA can come in the develop. To summarize, achieving tolerance through immunosuppression with steroid is a welcome idea, not at the expense of graft or patient loss. The rapid steroid withdrawal, completely steroid avoidance protocol compared to late steroid withdrawal have yielded promising patient and graft survival outcomes in low-risk individuals using aggressive induction therapy. Mind your aggressive induction, that also increases your cost of therapy and also other infectious complications. The better designed studies should be conducted among medium and high risk recipients to come up with robust evidence prolong the lifespan of patient, deliver to them improved quality of life. Thanks for surviving through my talk.
Thank you, Dr. Mohanty, for an excellent talk. Any questions from the audience, or I'll just ask one question. As I understand that the toxicity of steroid is more dose dependent and with cumulative effect. And there is a concern about early withdrawal. But what about the late withdrawal? We withdraw these steroids after 5 years of transplant. And there are some studies which shows that even that is feasible. So what is your view on that?
Actually, definitely, it is dose dependent. The steroid toxicity is dose dependent. There is no doubt that. Initially, when we started transplant, the dose was very high. Nowadays, we are giving very minimal 5 milligram maintenance dose. And we are comfortable with that much of this thing. And regarding this late withdrawal, actually, I have not come across any study which is late withdrawal.